In this video, we will discuss about some of the clinical application of occlusion in advanced dentistry, specifically when we are doing reorganized approach. So what are the application or knowledge of reorganization can help you in treating cases? So one of the advantage of having knowledge of reorganized approach is that you can treat smile design cases much more comprehensively and be able to have much more control with the shapes of the teeth, and you will have less failure if you know occlusion much better. It also helps you in treating full mouth reconstruction cases or anterior posterior teeth where the wear is extensive. It also helps you in full arch implant cases. So let's look at this case which we briefly touched upon previously in previous video. So this young girl was referred to me. She was 24-year-old when I saw her for veneers on front two teeth. And as you can see, her dentition is very worn down and there is mild to moderate wear. However, if you need to understand the age of the patient. If we leave her like this in 10-15 years time, the wear would be substantial because she has got a lot of dentine exposure, as you can see from the maxillary arch where the premolar, first molar, there is chipping and there is some wear, and there is a minor wear on the mandibular teeth as well. So when you look at this case, you need to think, how are you going to treat this case? Are you going to conform with patient's own dentition and just do 2 veneers? Or are you going to reorganize and do full arch restoration? If you're treating this patient and if you're mounting model, what would you do? Would you mount model in CR, CO, or MI? Are you going to take further information, further records you're going to need, or for mounting, depending on what type of mounting you have chosen? What kind of instructions you're going to give laboratory? And what material are you going to use to treat this patient? Now, I have touched upon before that I ended up treating her as a full mouth reconstruction case or almost full mouth reconstruction case because many of her teeth had exposed dentine. So the plan was to do adhesive restoration, direct veneers on the anteriors because she was young and I didn't want to do any invasive dentistry on her at this stage, because I did tell her that in her lifetime she will need another reconstruction because whatever we do is not going to last her for a lifetime. So we ended up doing adhesive dentistry, direct bonding of the all the teeth except lower anteriors. And the steps we followed was, first, I almost for all adhesive restoration full arch cases, I would take impressions. I would then decide whether I want to mount in CR, CO, or MI. If my first point of contact is good enough and I have enough restorative space when the patient closes in that first point of contact, then it becomes easier to treat that patient because the adaptability is much easier because you're not opening vertical dimension. However, I wouldn't be worried about opening vertical dimension at all. I've opened vertical dimension as far as 5 millimeter and there is no issues with that. However, if you open posteriorly a lot, anterior restoration becomes trickier to deal with because you have much more space anteriorly. So you need to sometimes assess how much space you need. And sometimes you end up doing direct restoration in some of the spaces to avoid drilling teeth and doing indirect restoration because you don't have enough space. But doing this reorganized approach gives you freedom where you can create enough space and you can create as much space as you like. Once I've mounted the models, I've assessed them, I would then do a wax up. And this is where you need to give technician a specific instructions. You need to tell technician exactly which teeth surfaces you're going to bond your restorations on, or you're going to do direct bonding on. Because in my opinion, when you send the models or to technician and don't give them a strict instruction as to which surface you want them to wax, you will get the model back with the whole surface waxed up. But if you're doing just the occlusal bonding of the composite, you don't need wax on the buccal aspects, and that is not a true replication of what you're going to be able to achieve for patient at the end of the treatment, unless you're going to do the whole build-up of the whole molar, and that is usually then deal with the indirect restoration. So I would tell technician, so I told technician in her case that I will be doing upper anterior 3-3 palatal and buccal composite veneers, and posteriorly occlusal composite veneers, direct veneers. Same thing with lower molars, and not doing anything with the lower 4-4. And the 5s will be implant restorations. Once the wax up is done, I would do a mock-up, and that gives me a good position where I need to place my implants. And I would place the implant, and while it's healing, I would start restoring the rest of the teeth. But initially, once I've done the mock-up of the wax up, so I would take the indices from the wax up, put some temporary crown and bridge material, and directly place it in patient's mouth, remove the excess, and you would see in a minute how it looks. And patient can then leave like that and have it for a week, have a trial to check whether patient likes speech and the height of the teeth and the length and shape, if patient's happy with it. Once patient's happy with that, then I would do upper and lower anterior, usually 3-3 definitive restoration in bonded cases, where I'm doing composite direct bonding. If you don't have enough time, you start with the lower arch. Make sure the lower arch 3-3 is where you want to be and straight, and then build the upper 3-3 palatal backings, and then call patient again to do buccal direct veneers, because what I find is having a longer appointment, you tend to get tired and the outcome of the result is not as great. So break them down, but keep them close together. So don't leave the appointment very long distant apart. Once that's done, I would, on the same day, once I have opened the occlusal vertical dimension, I would use bite registration, which is created from the wax up, to make some provisionals and put some provisional at the back. If you don't have enough time, or if it's not fitting, you could use a small GIC restoration, glass ionomer restoration, and just squeeze on occlusal surfaces until the opposing tooth contacts, and just use them as a stop. However, this is not a long-term solution, and you need to change them frequently. And then once that's done, you can then start restoring posterior teeth, either sectional or one side at a time or one arch at a time. And this all depends on how controlled you want to be. I tend to do usually one side at a time if I know the technician and I know that technician is going to be able to replicate the smile really nice. If I'm not sure and patient's really demanding about the smile line, then I would do a maxillary arch first to make sure that the occlusal plane is right, and then do the mandibular arch later on to get the bite correct. Once that's all done, you need to make sure you give patient something to stabilize your restoration and make sure that those restorations does not break in future. So this is the case where I have just done a diagnostic mock-up of the front teeth, and you can see that the occlusion is on the anterior is as good as you want to be. So there is a canine guidance and there is an anterior guidance as well. Because the teeth are healthy apart from the tooth wear, I didn't mind distributing the guidance. This is once the full arch is done, you can see the point contact on every single tooth. And this is the guidance scheme where the lateral guidance is on the canine, a little bit on the premolar, because I wanted to make sure that the lower premolar is not guiding because it's implant. And then anteriorly, I had 3 incisors in guidance. Because of the position of the upper left 2, it wasn't completely in guidance. Patient didn't want orthodontic treatment, and to be honest, the shape was fine, so we decided not to go ahead with orthodontic treatment. However, in majority or many cases, when you're doing full mouth reconstruction, you need to consider orthodontic treatment in order to move the teeth in the right position for you to be able to restore it properly. And I always tell all my candidates that when I do hands-on courses that restoratively, we are very weak as planning orthodontic treatment, because when I look at the cases, maybe 15 out of 20 cases, I can justify doing orthodontics before restorative treatment. So having a good orthodontist side by, or having a knowledge of some short-term orthodontics or some sort of orthodontics treatment is a good idea. I would recommend liaising with some of the specialist consultants or orthodontists and have a joint case discussion with them as to what is achievable in most of the cases. And this is after the finished restorations, upper and lower arch. We used occlusal surfaces of all the upper teeth, maxillary teeth, to increase the OVD and just restore the lower teeth in its existing shape and form, molars. Now you can see this is all bonded, and yes, this is not permanent. They will chip, they will stain in her lifetime, but this gives patients some time to then start with the next step, which will be indirect veneers at some point in her lifetime. And we ended up giving her similar splints, something like this at the end. Now, this is a little bit more extensive case where a patient came to see me with upper anterior crowns which were failing, they were bleeding, and there was caries underneath. However, at the same time, when we assessed, we can see that there is severe wear on the lower anterior. Now, when we are treating this kind of cases, you need to consider crown lengthening, because you can look at the height, which is very short. And in this patient, we ended up taking the molar, which was heavily broken down, restore the anterior teeth with provisionals, and canine and laterals with some composite restorations to give nice guidance. Once that's done, posteriorly patient ends up with the open bite, and then you end up restoring them. We ended up restoring them with onlays, upper and lower arch, to stabilize the bite, and then came back with the anterior teeth and did the indirect restoration on centrals. So another tip which I can give you is, when I'm doing indirect restoration, I tend to do anterior indirect restoration at the end, because once you have mastered your occlusion, once you know that you got really good guidance in place, you can get those shapes in really nice form. Sometimes if you do anterior indirect first, and then if you're dealing with the posterior, then you can struggle sometimes to disclude those anterior if you want to. In this case, we wanted to disclude those two centrals because they were heavily filled and post and core crowns. And this is what we ended up doing. Similar case, which we discussed early on, where patient with a heavy wear, edge-to-edge occlusion, and lots of broken down teeth, as you can see posteriorly. and occlusally you can see that there are severe wear and lots of broken down teeth. However, there were some posterior teeth with the gold onlays or crowns were stable. So we decided not to do anything to them and work around them, because the lower arch, the curve of spee, wasn't too bad, and we were about to manage that, keep it flat and work with the upper arch alongside it. The missing teeth were restored with implants. Anterior teeth were prepared for crowns. We could have gone with adhesive dentistry in this case. However, patient was 75-year-old, and for longevity, we decided to do indirect porcelain crowns for this patient, and we ended up having a decent result. In this case, you could decide to do a crown lengthening. We decided against crown lengthening because, as you can see, the 3 to 3 teeth are already gingerly pretty high, and if I do crown lengthening, we will increase those height again, and then we'll have to go much more posteriorly to give those teeth a crown lengthening as well. But without crown lengthening, we managed to get much better result. And this was the lower anterior. The lower anterior were restored using composite resin, and this is what I do a lot of time. When you have composite resin, which is very minimal wear, and if this wears, you can always convert that into a porcelain veneers. However, once we finished, we gave patient Michelin splint to make sure we avoid any further wear. So I hope this has been useful, and with regards to advanced uses of occlusion, this lecture is not enough, and you need to have a further knowledge, which I'm hoping that this course will build upon, and you will be able to take that first step towards doing full mouth reconstructions. In my journey, I started with doing adhesive reconstructions first because it is more forgivable. So if you do some mistakes, you can take a little bit composite off, you can change the occlusion a little bit compared to indirect restoration, because indirect restoration, you need much better help of your technician, and you need to have a knowledge of each step and how to proceed them. So in the beginning of this part 1, we discussed, or I raised a few questions. One of the questions was how many times you have replaced amalgam with amalgam or a composite. You have to really carve the tooth down in order to make sure that the patient can close their teeth properly. So I hope by now you may be able to realize that you need to make sure that you consider occlusion. Consider that the tooth is in CO, because if it is in CO and if you remove that surface, then the jaw goes upwards, reducing the occlusal vertical dimension. And that's why when you do the filling or restoration, you have to carve more for patient to be able to bite that. The other common scenario is because you're replacing old amalgam or old restoration, which is already worn down, there is a supra eruption of the opposing arch tooth. And because of that, there is a plunger cusp effect, where there is one cusp which is just going into that cavity. You do need to be able to communicate with patient before you start the treatment that you may have to adjust the opposing tooth in order to get a better occlusal plane. If you explain this to patient before you start the treatment, then it's a very good explanation. However, if you've done the restoration and now you're explaining this to patient, then it can come across as an excuse of poor workmanship to the patient, although you're trying to do the good job. So make sure that you mention this before you start treating that tooth to the patient. Now, the second question we asked is how many times you've prepared last standing tooth for a crown or for a restoration, and you know that when you prepare for a crown, you've done enough reduction, but when the final crown comes in, you are end up having, to reduce the crown so much so that it becomes very thin or sometimes perforates. So I would advise you to consider that that tooth may have a CO contact, and I hope by doing all this exercise you are familiar with how to check the first point of contact. And I would recommend that whenever you're treating posterior teeth, do that, because especially 6s and 7s, you're very highly likely to get that on those teeth. And because you eliminated that contact, that resulted in mandible shifting upwards. So let's look at this small video in order to make you understand. So this is just a deflective contact, and when you patient close their teeth, this slide causes mandible to move forward. Sometimes if the slide is very hard enough, it causes trauma to the anterior teeth. When you eliminate that slide, mandible moves backwards, as you can see in this one, creating an anterior open bite. And this is what we discussed before. Now, this is the case where you have prepared last standing tooth, where there was a slide, and now the jaw moves upwards. And when that happens, you lose this space which you have created. But in patient's mouth, the condyle has just seated better in upward and superior position. So this is something you need to be aware of, and this happens very often. But as I said, because of the adaptive capability of the patients, you don't notice it, and patient just jaw gets used to with the new first point of contact. Now, the third question was, have you treated patients who repeatedly breaks or chip restorations or teeth? In these cases, you need to consider parafunction, deflective contacts, or non-working side contacts. And this is something you need to understand by doing more and more clinical assessment. And the more assessment you do, the more you will realize why teeth break and why things happen the way it happens, because there is always a reason why patients end up breaking the tooth one after another, or why that veneer keeps chipping off or keeps pinging off and debonding, or that one crown when you're doing 10, why that one crown keeps coming off from the, if you're doing a 10 crowns, you put them using temporary cement, why just one crown keeps coming off all the time? And the answer would be in the occlusion. So I hope this has helped you in applying your knowledge of occlusion in your clinical practice.